What are state and local officials doing to improve access to treatment across the criminal justice system, and what is still needed to ensure a safe and successful return to society, which we were just discussing? Joining me now to go into this are Dr. Ross MacDonald, Chief Medical Officer for the Division of Corrections of New York City Health and Hospitals. He's got a big operation. Dr. Kimberly Sue, Medical Director of the National Harm Reduction Coalition, a national advocacy organization promoting the health and dignity of those impacted by drug use. She's also core faculty in the Yale Program in Addiction Medicine. And Dr. Justin Berk, Medical Director for the Rhode Island Department of Corrections, and Tracie Gardner, Senior Vice President of Policy Advocacy at Legal Action Center. She previously served as the Assistant Secretary of Health for the New York State. Thank you all for joining us. Let's just have a roundtable, discussion about all of this. Feel free to jump in, but I want to start with Dr. Sue. I want to read you something that I really like that you apparently said, or it's in my notes here. Maybe somebody else said it, but you said harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. And I just don't hear, it's what I was just discussing with Sheriff Kincaid, who I think gets it, but I don't think most of the system gets it. I just would love to kind of, take this organically from where your, efforts and movement are, and how much of a lift do you see and experience? You can discuss with our other colleagues here in this panel, but nationally, how much of the system gets where you're at and is trying to achieve that?
Thank you so much for the question, and I'm delighted to be here today to talk about these issues. I think the question of how much the rest of the country gets it is debatable. I think that for the first time, President Joe Biden said harm reduction in the State of the Union. But we still have a system in this country that is largely violent and stigmatizing to people who use drugs. And so that is why we always talk about the practical strategies that we can do as doctors and as clinicians and people advocating for policies. But we talk about it as a social movement, which was started by people who use drugs and letting them lead and working with them in a human rights-based approach. So you often hear in the U.S., we don't really talk enough about a human rights-based approach, but really people deserve dignity, compassion, and respect, regardless of if they're using or not, and wherever they are. So that is the grounding principle of all the work I think many people on this panel.
With what the sheriff just said, if I may, she used the words. I was asking, is there, when you deny or you're not providing that kind of support with people that are in jails and prisons, is that another form of impunity in that? And she used the words cruel and unusual, in her statement, which was a surprise that she went there, but she did say that. And so it raises this interesting question about rights and whether some of this is actionable, on behalf of those in the justice system. Dr. Sue.
Right. And I think Tracie is really well positioned to talk about this as well. Not only, the lawsuits that are coming to prisons and jails for providing this life-saving medication that we use, like methadone and buprenorphine. And, Ross and Justin also implement these critical programs, right? But even nursing homes, right? For example, we're having to file lawsuits against nursing homes because our patients in the hospital with endocarditis are being stigmatized and they have nowhere to go. So they just say, oh, we can't give them buprenorphine or methadone. And it's simply because of their treatment.
And Tracie Gardner,
in on that?
Yeah. Tracie Gardner would love, because I know you are actually, I love your tweets. You have one here: Black, brown, and indigenous people are disproportionately punished for using drugs instead of being referred to treatment. You refer people to a new report, but I know you're helping to navigate this. How big a problem is it out there that needs to be addressed?
Well, again, thank you for this opportunity to talk about these issues. And I think that the problem is deeply ingrained, and want to remind some of your viewers, this is not our first opioid epidemic.
Right.
We had one in the 70s, and we responded to that with criminalization and putting people in prison and jail. And that's about when Legal Action Center got started to say corrections is not the environment to treat people with this health issue. And I would contend that still isn't, although Dr. MacDonald runs one of the first jails that provides medications for people who use drugs or people who have problematic drug use. And they've been doing it for 30 years. The real question is, why has it taken so long for the correctional system to replicate what New York City has been able to do and do well? So, what really needs to be, I think, emphasized is if we adequately treat people in the community, often they won't end up in jail. Jail is an opportunity, but it is not the best place to provide addiction treatment. And so I think that is a little bit of what we are talking about in all of the examples that we have failed in a way that we have law enforcement and the correctional system providing a healthcare service and healthcare treatment when in fact it should be in the realm of health. And that's where the resources are as well.
Well, that's great. Well, let me bring Dr. Berk and Dr. MacDonald in, from Rhode Island and New York, respectively. And we actually, it's a question I asked. We have some questions that have come from the audience. And Gina Carbaugh, the advocate for Richard Carbaugh's Hope Foundation, asked, how do we go about getting more recovery efforts and recovery treatment options into jails or prisons, with both of you are already doing? But Dr. Berk, recently I had Senator Sheldon Whitehouse discussing some of these issues, and he really gave us a kind of tour de force, if you will, of a lot of different dimensions of what Rhode Island was trying to do, was to create a blanket, it's sort of a foundation of treatment options and respect, but would love to have you share that with our audience, what you've been able to achieve in Rhode Island.
Absolutely. I'd echo everyone's sentiment so far, and we're very proud of the achievements in Rhode Island. I think the program was developed in 2016 in response to the opioid overdose epidemic, where the governor at the time wanted people to get together and say, how can we address overdose deaths? And there's clear evidence that a lot of these individuals that struggle with opiate use disorder find themselves incarcerated in jail or prison. The natural progression of addiction is often to find themselves in jail and prison. And so this is a high yield target to intervene in people's lives, to really try to help provide treatment and support. And so in 2016, Rhode Island created the first statewide comprehensive medication for opiate use disorder treatment program. And it's worked extremely well. We're very proud. The evidence suggests that for every 11 people you treat, one life is saved. And so this really demonstrates how important treatment is. And just to echo, Tracie's comment, that I think while we're very proud of the work that we do in our comprehensive jail and prison unified system, it really points to the need for treatment and access to treatment. And not relying on incarceration to be the one that provide that treatment, but really to support community access.
Dr. MacDonald, can you share the New York story with us and what you've seen getting traction in your system? And again, I'm always interested in not only what's happening by way of, being humane, but also how do you help someone on their journey beyond the prison system to kind of come back into opportunities where they're not basically subjected to a vicious cycle of, rotating through the justice system because of an inability to escape the gravity of that drug use disorder?
Thank you. That's a critical question. And yes, so the Rikers Island KEEP program, which is the nation's oldest jail-based opioid treatment program, was actually started by many of the people who pioneered the treatment of methadone in the community in the U.S. And so 40 years ago, people understood that heroin users were being incarcerated in New York City and that we needed to get them treatment to avoid some of these negative consequences that we've heard described here. I think what we really have to grapple with is how decades later, this has not become the norm in correctional settings across our country. And it really speaks to a larger failure of the war on drugs, of an approach in this country that sought to solve this problem by criminalizing it. And I think to your question, it's critical to think about how do we support people in the community after release from jail, but more so, how do we avoid jailing people in the first place? Because jail itself, incarceration itself, is a counterproductive intervention for substance use disorders. The things that are most protective and help people achieve and maintain recovery are the positive things in their lives. They're the jobs, the relationships, the housing in particular is a huge problem in New York City. And periods of incarceration, even short ones, destabilize all of those things. So it really requires us to rethink how we approach the criminalization of substance use disorders. But absolutely, if we're going to incarcerate people with substance use disorders, which we do at a very high rate all around the country, we have to have the standard of care medications available to treat those conditions.
You know, I want to ask all of you know this, and Dr. Berk, I apologize if I butcher this word. I'm not good at medical terms, but buprenorphine, is that right? Buprenorphine? Close enough. And I know that medical assisted therapies and treatments are part of the picture. And I want to ask you a political question. You know, we live in DC here, but I know that we're also dealing with states and localities, and so I don't even presume that the federal level can, impact all these different levels. I'm just sort of interested, as I understand those that are trying to provide medical assisted support, particularly when overdoses have occurred. What is the political driver that gets in the way of wide provision and prescription of the drugs that will help people live? I don't get it. So what's the block?
This is an outstanding question, and I think highlights what the barrier is to accessing treatment in the community, but also in corrections. You know, you previously asked the question, why is no one else doing this? Why, as Tracie asked, why is no one following the model that Rikers has been put in place for decades? And the truth is stigma. There's no reason that this is not more widespread. About 50% of individuals that have overdose death often have criminal justice exposure. There was a great article that came out looking at Maryland data that showed nearly 50% of people who died from overdose had some criminal justice touch within a year. So politically, philosophically, from a science-based, evidence-based background, if you're looking at who should we be targeting to try to help in the opioid overdose epidemic, it's people who have criminal justice exposure and experience. Why aren't jails and prisons implementing this as some of the model states have? And we consider ourselves a model state in this. And I think it's because people are not wanting to invest in the treatment of people that they feel are not equal, that they feel like need to be punished. And it's overall, I think, just a very harmful public health strategy.
I would ask Dr. Sue and Tracie Gardner as well. You're both on the front line of essentially a human rights-based approach, a civil rights-based approach to thinking about this. I'm always interested in whether I tell people there are ways to pursue differences in public policy earnestly, and then there are these bank shot approaches, accidental alliances, odd bedfellows that may, help expand our aperture on understanding. I'd just be interested, Tracie, in your experience, what's been successful at opening the aperture? Maybe it's lawsuits, which I knew. Maybe that's the court system, opens people's minds and you create liability. But I'm just sort of interested in what are from your experiences, what can you share with our audiences that are in their own community struggling with this that help get, realization about stigma and treatment in, more holistic ways than we have now?
Right, and that's a really great point, because stigma is, in my opinion, a form of oppression. It's the way that we punish people when they're not behaving in a way that we find acceptable. Legal Action Center just, finished a really important report on how people who are perceived to have substance use disorders or who do are treated in our emergency rooms. And we have found that in many cases, the treatment of people who come in, particularly after a non-fatal overdose, violates several important laws, including the Americans with Disability Act, as well as a few others. So not only is it medically unwise, but you're also violating people's rights. And this idea that we could actually address the symptoms of the health emergency that individual is in an emergency room should be a no-brainer. We do it for people who present with asthma, with heart complications. The immediate response should be healthcare. But we have a lot of, there's a lot of antipathy for people who use drugs. And what I would say is when you engage people who use drugs, that in a way that acknowledges that they know what works for them best. No one is born saying they want to grow up to be an injection drug user. So, you know, and using drugs does not eliminate the ability to want to say, this is what would really engage me. So, you know, you talk to Dr. Sue about her patients and the people she's working with, and they are absolutely the primary expertise in how we build these systems that don't alienate them, but actually engage folks well before they end up into the justice system and even after.
Well, let me ask Dr. Sue and Dr. MacDonald a quick question, then we've got an audience question. But I want to ask this question, and it's just, I'm on the opinion side of what we do here, so I'm allowed to have opinions. And I guess my opinion is that, you know, when it comes to the concept of harm reduction, you know, the debate as I see it out there is this kind of weird one in America where we pretend at some level to be, you know, Puritans, that, you know, people don't drink, they don't smoke, they don't have crises, they don't have behaviors, and that there's this notion that if you talk about harm reduction, some people say, well, then you're giving permission and space for people to deviate from that ideal. And I find it really offensive, you know, that notion, because I just don't find it based in reality. But I imagine that must be one of the arguments you run into a lot. And in my mind, it's like, you know, go look at your family, go look at the people you're related to, go look at the people you like in the community. Everybody has it. It's like, come out, you know, just come out and, you know, look at who people are. So I'm just interested in what do we do from both of your experience to just make reality more embraceable? Does that make sense?
Yes, and I'm just going to jump in here because I know Dr. Sue is going to speak to it. But harm reduction is not unique to the issue of drug use.
Of course.
We use harm reduction. Filters on a cigarette are harm reduction. Seat belts are harm reduction. For people who are going to do the activity anyway, we have a number of ways to make it safer. And that is fundamentally what harm reduction is about. It's not about encouraging people to do this behavior. It's about ensuring that they do it safely.
Sure. Thank you. Dr. Sue?
Yeah, I mean, really, it's about humanizing people. It's about meeting people, you know, where they're at, and you know, it's not a revolutionary strategy, right? It's like Tracie said, it's what we do in the clinic. We make sure people are wearing helmets. We make sure people are wearing seatbelts. We make sure people have the equipment that they might need to use to inject or to smoke substances. You know, like you said, we have a very puritanical society here in the U.S. It's a very disingenuous stance in many ways. I write about this in my book, and I go back to sort of, you know, some of our early writings about prisons and jails in the 1800s, and this idea of reformation and absolving of sin, like that's very baked into a lot of our current understandings of substance use. And, you know, so many people, you know, all of us here have used psychoactive substances, you know, to feel better, to achieve sleep, you know, to have pleasure, right? And so these are all very human things. We've lived with intoxicating substances and managed to make them and use them for, you know, thousands of years in all societies and cultures, right? And so I just want to enable people to live and to live with dignity and respect. Right,
and let me final word for the audience to Dr. MacDonald. But I have to say, Dr. MacDonald, I don't know if you know her, but someone I know who was incarcerated at Rikers and who's come out as a Reverend Vivian Nixon, and I find her to be an incredibly inspiring person who works with those, particularly women coming out of prison who have had all sorts of disorder challenges, mental health challenges. I met her through the Aspen Institute program called Ascend, which tries to kind of look at how do you change these patterns across the way. Now, I know that, and I know Vivian Nixon and admire her so much, but I have to say that until this happened, I did not know about the right. What can we all do to help give you lift? I mean, you're sitting with one of the oldest and best and major programs, but I'm just wondering, what do you need to help spread the word a little bit on the practices you're using? You're muted.
Sorry. Well, that's a great question. We've tried to spread the word, and I've been lucky to collaborate with all the other panelists here as part of a movement to try to help our colleagues around the country achieve what we've done for many years. I think it's important to point out that this work is not easy. To provide these medications in a complex location like a jail or a prison is difficult, it's costly, and it requires a real societal commitment. I think what we need to understand as a society, though, is when we incarcerate people, it comes with an obligation to provide them with treatment. And so I think we're happy to help, and thank you for today spreading the word and to provide technical assistance to other systems. One challenge which we should mention is that many security people are mostly concerned about diversion of medications in the facilities. And one of the most important messages is that that is an issue that comes up when you implement these programs, but it's a problem that can be managed and can be solved. And it's not in and of itself a reason not to use the medicines that we know save lives.
Right. Well, we have a question for you folks from Don Mathis. Don?
I'm Don Mathis, a certified peer recovery specialist at Voices of Hope in Aberdeen, Maryland, and former case manager for our county's 4 drug courts. My colleagues and I thank the Hill for hosting this important event. My question, what strategies and messages are effective for reducing the stigma that some in law enforcement have against people with substance use disorders?
Terrific question. It's been something we've been talking about. But why don't we start with Justin Berk? Dr. Berk?
I think this is an incredibly important question, and it's a tough question, especially when, to Dr. MacDonald's point, correctional officers for years have been working to get buprenorphine and medicine similar out of the jails and prisons, out of diversion efforts. And so to one day say, no, this is medication, you were letting it in droves, causes some confusion and mixed messaging. And I think over time, people recognize when they see the miracle drug of buprenorphine or methadone, what people can do, where they can change their lives from rather than waking up in the morning trying to find something on the street, honestly, to prevent withdrawal, prevent them from getting sick. They can go to focus on their family and focus on their job and focus on having a good quality of life. Things that are still need supports. Just because someone's on treatment doesn't mean that all of their social stressors go away. And I think this is an important part of the reentry process. But I think as more people become exposed to individuals that they are surprised have opioid use disorder, and more people who are exposed to the miraculous effects of treatment, I think that is really the big thing, and to talk about it and to share that news.
Right. Thank you. Let me get quick snapshots from the other 3 of you. Dr. Sue?
Yeah, I mean, there's a lot of, I'm actually giving a talk on Friday on stigma and what we can do about it. I think reminding people that this is a standard of care. If you have high cholesterol, I'm giving you a statin. I want to prevent you from having a heart attack. This is a standard of care. And when I went up to Albany County Jail and did technical assistance to help them set up their buprenorphine program, many people quit. And it was like, well, this is modern medicine. So if you don't believe, we're going to educate you about addiction and substance use disorders. And if you don't like it, you don't have to work here. So, that is, we want to bring people on board. But I think some people, many people have, a lot of experiences that we need to kind of seek and understand.
So we need to build literacy, honestly, right?
Yeah, and we need to just talk openly about substance use. Like you said, we're very puritanical, and so there's all these campaigns in New York City, for example, that has campaigns that say methadone and buprenorphine saved my life. I use naloxone to save my best friend's life, and they have people's faces, real faces of people who are on these medications who are doing well and thriving.
Thank you, Ross MacDonald.
Sure. So I think it's important to explain that medically, substance use disorders always mean that people have compulsive use of substances despite negative consequences. That's the condition. And I think so much of what we've done over the last few decades is try to pile on more negative consequences. And I think people can look back or think about loved ones in their lives who've struggled with this and understand that we're not going to punish our way out of this problem. And that's really how I try to frame it.
Well, thank you. And Tracie Gardner, I'm going to give you the last word, so let's make it great.
Absolutely. I'm confident that will happen eventually, just as all kinds of accepting of a norm, a standard of care, as Dr. Sue put it. Many of us have lived through the HIV epidemic, the early days, and we have known, and it's been demonstrated that syringe services programs, for example, which were very controversial at the beginning, then became very well known as a way to reduce infections and reduce mortality for people who use drugs. So I know that it can happen. We all know it can happen. It requires sustained support and education and technical assistance, but it's simply the right thing to do. And that just needs to be embraced, and I'm confident it will be.
I'm just going to say a little editorial comment before I thank all of you. This was an incredible conversation. The whole program was. And I'll tell you, people that are watching right now, you're already tuned in and you already get a lot of this, and we just appreciate you being willing to listen, to learn, to do this. Go talk to somebody who's not tuned in yet. I mean, I really think that the big issue here is that if you scratch beneath the surface, these challenges are much larger in our society than many folks realize. So I do hope that we'll share the story of Rhode Island and Rikers and, you know, what's going on in various communities around this country that aren't getting the support they need. So I'll just say it there. Go share this with someone else. I normally don't say that with our Hill events, but this is an important one. So Dr. Ross MacDonald, Chief Medical Officer of New York City Health and Hospitals Correctional Health Services Division. Dr. Kimberly Sue, Medical Director of the National Harm Reduction Coalition. Dr. Justin Berk, Medical Director for the Rhode Island Department of Corrections. Somehow we talk a lot about Rhode Island on our shows. Tracie Gardner, Senior Vice President of Policy Advocacy at Legal Action Center. Really appreciate you all being with us today. Thank you. That brings us to the end of our program today. A very big thank you to Indivior for its support and to all of you attendees for joining us today for these discussions. If you missed any of the conversations that I just said, we're going to have the video up from the event on our website shortly. Go show it to folks. I'm Steve Clemons. Be well.